Okay. Hi, my name is Alessandra Dorante. I am a student at WTAMU. This is my case presentation for Nursing 6342 Primary Healthcare 2 on 10/3/2025. Welcome back to my living room, complete with snoring dogs for your background sound effects. So today we are talking about our patient initials MR. He came in for a medication follow-up. He actually came into the clinic about 2 weeks ago, complaining of headache, complaining of just like general tiredness, but mostly this headache that had been persistent that wasn't normal for him. At that point in time, his blood pressure was found to be 187 over 100 in the clinic. He had no chest pain, no dyspnea, no any other symptoms of anything wrong at that point in time. So they prescribed him lisinopril, 5 mg, and drew some labs and sent him on his way and said that we will follow up in a week, which is the visit that we are now talking about. So his chief complaint was that he's here for his medication follow-up, he said. Um, MR is a 67-year-old African-American male. He is complaining of no symptoms at this time. He said that his headache has resolved. Um, he's again denies chest pain, palpitations, shortness of breath, edema, dizziness, syncope, or any visual symptoms. Um, we asked him to keep a log of his blood pressure, and he has not been consistent with that. He does have a couple readings for us that he wrote down, but not consistently every day. He has like 2 or 3 readings. Um, his past medical history, he has primary hypertension that he does not normally take medication for. He has hyperlipidemia. He has type 2 diabetes that he's been managing with lifestyle and diet. Um, and no other medical history, no surgical history. Um, family history, he said his parents did have hypertension and he had diabetes on his father's side of the family. Medications, he currently takes lisinopril 5 mg daily. He takes atorvastatin 20 mg at night, and then he also takes a baby aspirin 81 mg daily. He says he doesn't use any NSAIDs or any over-the-counter medications regularly. Social history, he lives with his spouse. He and his wife have been married for 65 years. They are retired. They, sorry, I got lost. They do exercise together. They like to go on walks. They take about a 20 to 30-minute walk a day, which is what he says that he's attributed his control of his blood sugars to. He denies tobacco use, alcohol use, no recreational drug use. His diet, he focuses on low carb interventions for controlling his diabetes, but he does admit that he eats like a lot of sandwiches, a lot of deli meat, and canned soups and things that he's found that he can do for a lower carb, but are higher in sodium, which we'll talk about later on. So objective data, vital signs on this visit were his blood pressure was 172 over 92. After 5 minutes of him seated, we repeated it and it was 168 over 90. His heart rate was 75, respiration 16, temp 36.6 degrees Celsius, O2 98% on room air. He is also a 6-foot male at 215 pounds. His general appearance, he's alert, he's oriented, he's sitting on the exam table when we walk in, he's well groomed, he's well developed, appears neurologically intact, but with the physical exam, we see Perla, no ears, eyes, nose drainage, no obvious injuries to the eyes, ears, nose, throat. He has no JBD. Cardio-wise, heart sounds are regular rate and rhythm, normal S1, S2, no extra sounds. He has no peripheral edema. His pulses are easily palpable in all 4 extremities. His cap refill is also less than 2 seconds in all extremities. His lungs are clear, no wheezes, rails, crackles, no shortness of breath, no tachypnea. Um, Neurologically, normal speech, normal gait, again, alert and oriented, no history of any neurological deficits. We did do a diabetic foot screen and we talked about checking his feet regularly. He does not appear to have neuropathy at this point in time as he has good sensation in both feet and there are free of ulcers and his nails are in good health. So his diagnostics, his labs that were drawn a week ago were his A1C was 6.3. And for this, the diabetic threshold is 6.5, but especially the ADA says that goals of less than 7 in older adults is acceptable. So he's well within the range of an acceptable level for a man of his age, especially only controlling it with diet. His lipid panel, so his total cholesterol was 202. His LDL was 115, HDL 50, and triglycerides 60. For context, our desirable levels are total cholesterol sub 200, LDL less than 100, HDL higher than 40, preferably higher than 60 if they have any kind of heart disease, and then triglycerides sub 150. And then we also did a basic BMP, CBC, and all labs were within normal limits for his age. Um, his baseline creatinine, BMP, BNP, sorry, and potassium were all reviewed. Everything's within normal range. He has no evidence of kidney disease at this point in time. So our assessment and differential diagnoses. So our assessment, our primary diagnosis is just going to be essential hypertension, which is I-10, ICD-10 code. His blood pressure remains in stage 2, which is over 140 over 90. The ACC and AHA recommends a combination therapy anytime the blood pressure is more than 20 points systolically or 10 points diastolically above the target. And his current blood pressure is more like 40 and 12 above the reasonable target for like 130 over 80 for a patient of his age with diabetes. Um, Comorbid diagnoses, we're also looking at mixed hyperlipidemia as evidenced by his LDL being 115 and his triglycerides being 160. This is an ICD-10 code of E78.2. And then we're also looking at type 2 diabetes without complications that is diet controlled. This code is E11.9. And like we said, an A1C of 6.3 fits the criteria for excellent control for an older adult. Um, so let's go to our plan. So our plan for controlling MR's blood pressure, we're going to increase his medications first. We're going to take the lisinopril. The lisinopril did a good job. He reacted well to it. He didn't have any complaints of any side effects with it. So we're going to go ahead and increase that from the 5 milligrams to 10 milligrams daily. ACE inhibitors are shown to be well tolerated according to the AHA. In older adults, they're good for diabetic patients, and they have been shown to decrease cardiovascular events. We are going to continue to monitor his renal function and his potassium levels, along with us adding hydrochlorothiazide. We're going to add 12.5 milligrams daily of hydrochlorothiazide in the morning. Combination therapy is recommended when the blood pressure is 20 points systolically higher than what we want our target to be. And thiazides are very effective in the African American community. So therefore, HCTZ is a good recommendation for this patient. And again, monitoring sodium, potassium, creatinine, BUN. We're also going to talk to him about monitoring his blood pressure consistently at home. We're going to give him examples of a log. We're going to print him out some papers, make sure that he has a monitor, make sure that he has access to that he knows how to use it. So that way he can keep better track of his blood pressures at home and we can get a better long-term picture of if these medications are working for him or if it's just like high when he comes in, if he's anxious at the doctor's office. Our goal would be to have his blood pressure under 130 30/80 if possible. For his hypercholesteremia, we are going to go ahead and increase his atorvastatin from 20 to 30 PO nightly. We decided not to jump him all the way to 40 just because he was kind of borderline on several of those numbers that he seemed like he was doing good. And he also has a history of doing well with dietary changes. So rather than jump him up really high when he was kind of on the border for medications for his hyperlipidemia, we decided to just educate him a whole lot about proper cholesterol, diet changes, increasing his HDL with healthy fats, decreasing his LDL by watching those saturated fats, along with doing things with diet, like decreasing sodium intake, so decreasing those deli meats that he likes to eat. Also, based on his age, being over 75 years old, a moderate intensity statin course is considered reasonable. And we will plan to recheck that lipid panel in 6 to 8 weeks. And then, so for monitoring, we're going to follow up with another BMP, CBC, full kidney function, full cholesterol panel in 2 to 4 weeks. Probably looking more at that 2-week mark if we're checking on the blood pressure results, making sure that the lisinopril and the hydrochlorothiazide is not taxing on his kidneys too much. We can also do a urine albumin to creatinine ratio on his next visit for screening of his diabetes. He hasn't had an annual visit in quite a while. And then he's been instructed to call us if his blood pressure continues to stay above 170s systolically. If it's not coming down over the next week or so, that he needs to call us and we need to adjust his medication sooner than the 2-week mark for him to follow up with us. Just following through on the education aspect of it, we talked about sodium. We talked to him about DASH diets, printed out some education, some examples of foods that were lower in sodium, some ways that he could pick the lower sodium options versus the higher sodium options when he's buying prepackaged foods. We wanted him to aim for under 1,500 milligrams of sodium per day. We emphasized fresh foods, reading labels, talking about things like that. Physical activity, he really does good with his walking, but we did talk about some balance exercises and possibly some weight-bearing strength exercises just to help in the future prevent falls, prevent long-term complications as he is getting older and at risk for fractures and things like that. A study that I found from 2022 found that there's a direct correlation between quadricep strength and longevity and the reduced mortality of falls. So encouraging him to do any kind of weight-bearing exercise, increasing his legs, increases his ability to get up off the floor if he fell down. And then it's shown to just improve overall quality of life and quantity of life. We encouraged him to adhere to his medications, avoid decongestants that could raise his blood pressure if he got sick as we're going into flu season. And we talked about proper home blood pressure technique, making sure he's sitting down, feet on the floor, resting, not talking, and again, making sure that he knows how to use that monitor and that he actually has a monitor. We did talk about some safety planning, that if his blood pressure was over 180 over 120 for some reason, that he needed to rest, recheck it, and if it still remained high, that he needed to call 911. Okay, and then our theory and rationale, we are still using Orm's self-care theory, talking about self-management skills, his home blood pressure monitoring, his diet adherence. That way we can help manage chronic disease better in these older adult populations. Okay, and I do believe that's it. In conclusion, MR is a 67-year-old male. He's African American, diabetes, hypertension, hyperlipidemia. We're increasing his meds and giving education per ACC and AHA guidance, and proceeding with close monitoring of his electrolytes and renal function. Thank you.